Good morning. Thank you for having me today. I am James Mayo. I'm a fellow at NYU right now in breast reconstruction, all types of microsurgical reconstruction, but just a brief background. I did my medical school in Charleston, South Carolina. I went on to Louisiana State University in New Orleans, which is really the birthplace of some of the more complex breast reconstructions, and that's where I did my plastic surgery. And now I'm here in New York to get even more training. And so by the end, I really feel like I'll have seen the gamut of breast reconstruction and seen lots of different cultures and really gotten a big grasp of the full scope of breast reconstruction. So I hope to relay a little bit of that to you today. And in my mind, almost equally important, I have a beautiful wife, a beautiful daughter, and many women in my family who I love dearly. And when I see women that come in for breast reconstruction, I see my family in all of them. And I think having that empathy and seeing your patients as your family is very important. So we're supposed to start off with some quiz questions. The first question is, what is the high-end percentage, or what is the greatest percentage reported of people who undergo breast reconstruction after having a mastectomy? So how many people do you think have a mastectomy and then have reconstruction? Okay. It's actually only 40%. And all of the answers will be included, and you'll see them in pink in my talk too, as when I kind of talk about them. On average, what percentage of people are covered to undergo breast reconstruction? And this has already been touched on. So 40% actually get it. How many people by law should get it? And that's everybody, and we'll talk about that as well. When we start talking about breast reconstruction, how many types of breast reconstruction exist? Main types. I don't know. This is kind of getting more specific, and you'll know by the end of the talk. But two main types. Most people got. Well, actually, it's a full gamut there. And then finally, there's one of the types is called autologous reconstruction, which is our own tissue we use to reconstruct the breast. And what is a characteristic of autologous reconstruction? Is it that it takes less time to perform the surgery, that it's a warm, soft, permanent reconstruction, that it requires more operations in the long term, or that some centers think that you can actually radiate this type of reconstruction? And you're right, it makes sense. Your own tissue, it's warm, soft, pliable, and we'll get into that as well. A couple statistics. I don't usually like to do a lot of statistics, but I think it's important. Some of them were already touched on. The first number, 2.5 million. There's a lot of cancer survivors in the U.S., and so we are identifying cancers, and we are treating them well, and that's great, and it's improving. Previously 65%, now 90% of patients with breast cancer have a 5-year survival. And so that means that with more mastectomies, more treating of breast cancer, there's more reconstructions to be done. And also mentioned already was prophylactic mastectomies, when you remove a breast to prevent the formation of cancer, usually due to a genetic cause. This is increasing. So all of this means that there are more opportunities for breast reconstruction, yet up to only 40% of patients are actually getting this reconstruction. So how we improve that is stuff like we're doing today. It's education, communication, and making sure that it's available to people. And like we said, on a national and a state level, there are laws stating that every reconstruction should be available to every patient. When I look at reconstruction with a patient, I think of three main things. I think of communication between team members, oncologists, radiation oncologists, surgical oncologists, reconstructive surgeons. We have to talk to each other, and then we have to talk to you, the patients, and get your feedback. And so we educate the patients on treatment plans, options, but also patients educate us on their wants, their desires, their fears, and their goals of their reconstruction. And then we all work as a team throughout the whole process so that we have success. My role as a plastic surgeon is always first to review the cancer plan, because I want to make sure that the patient understands the main focus is, number one, treating the cancer, understands her plan, and that I understand her plan, because that's going to change my reconstructive decisions. And so we discuss that plan. I discuss with the patient her goals, her medical history. We go over whether she smokes or not, her body habitus, and we start to develop a plan. And then we start to talk about timing, and that goes to what was already talked about, radiation. While radiation does a great thing and is an integral part of treatment for breast cancer, there are effects on the skin, and there are effects to the tissues. And a lot of the reconstructions we do can often be harmed by that radiation. So if I know that radiation is going to happen, I'll often wait till after. That doesn't happen for all cases, but it's important to know. It's important to talk about the timing. And then finally, patients should know about the course and the complications that might arise. And at the end, we've now funneled this big cloud of possibilities, hopefully to one or two options for breast reconstruction, and the patient and I decide that together and we move forward. It's important to know the breast shape when you're reconstructing a breast. It's not just about moving tissue or putting an implant in and having something there. We now are getting better and better at reconstruction, and so the aesthetics of reconstruction are getting better. And so it's important to know when you look at the breast in a young female, it looks like more as a cone shape, and that is created because of the presence of a nipple here, creates that cone. Yet when you have the breast removed and the nipple is removed, that cone is removed, and our reconstruction often is more rounded. And it's difficult to overcome. It's difficult to reconstruct. And so often you see reconstructions be more rounded and lose that cone. One way that we can avoid that is by having a nipple-sparing mastectomy. Now, we would never have a nipple-sparing mastectomy where we save the nipple if it were a risk. But in some patients, it is acceptable and is shown to be safe. And saving the nipple has obvious psychosocial implications for being a good thing, but it also, as I alluded to, has the unique features of keeping the nipple that we have a hard time reconstructing, like texture, color, shape, and volume. Oncological criteria have been developed to say who is a candidate for nipple-sparing mastectomy, and they depend on tumor size, tumor distance from the nipple, any unfavorable characteristics to the tumor, and so that's talked about between the surgical oncologist and the reconstructive surgeon. We plan together. And so, again, communication is very key. Then there are relative reconstructive criteria. Small to moderate-sized breasts tend to favor better with nipple-sparing mastectomies, and also women over time tend to develop ptosis, where the breast tends to sag, and women who have more ptosis are less likely to be good candidates, although in some hands we are able to overcome that and get good results. So those are relative indications. All reconstructions are done in stages. Very few can all be done in one sitting. And so a woman comes in, she may look like this prior to her mastectomies. She has a mastectomy after reconstruction stage 1. We'll recreate the breast mound. This is a woman who had her abdominal tissue used to recreate her breasts. And you can see she had no nipples, but she had most of her skin spared. And this is after the first surgery. In 3 months, she'll undergo a second surgery where we'll reconstruct the nipples with her own tissue. And you can't see it here, but a lot of times this is an opportunity for us to improve the aesthetics of the reconstruction. We can actually harvest fat by doing liposuction, and we could fill out these areas where you can see some volume deficiencies. And when patients have scars, we can lower those scars or do different scar revisions to really start to fine-tune the reconstruction. And then finally, at some point, there's actual people that specialize in tattooing that can recreate the areola. As you can see, this patient had an areola recreated around the nipples, and they have all shades. They choose it with the patient. They have all shades of colors that they can do. But basically, and all of this is under the umbrella of reconstruction, so all of this is eligible to all patients. Like I said before, there are two types of reconstruction: implant-based, which is a synthetic material, or autologous, where you use your own tissue from your body to build the breast. Implant reconstruction tends to be the simplest and the quickest type of reconstruction. We use synthetic bags. These are the same implants used for breast augmentation. They're either filled with a saline or a silicone, and they're placed under the chest muscle. The breast tissue's already been removed. They're placed under the chest muscle, and oftentimes a biologic mesh is used to keep the implant from falling down over time. In a single stage, this can be done, meaning you can have your mastectomy and get your implant in a single stage in a few patients. These are patients that undergo nipple-sparing mastectomy that after having their breast removed, their skin and fat over the implant is thick enough because you don't want to feel the implant or see rippling from the implant. And patients where there's no concern about the skin quality. Also, radiation is a very big consideration. There are a few centers that are okay with radiating implants, but the majority, I would say, in the United States right now would prefer not to radiate an implant because it can alter the aesthetics afterwards. It increases the rate of having what's called capsular contracture, which is where the body forms scar around the implant and causes pain. And it can also, in some centers, make it a little bit more difficult for the radiation oncologist to focus their radiation how they want to. Again, I put a star there as it changes based on the location. Here's an example of somebody that underwent immediate reconstruction. She actually has quite large breasts. She does have ptosis that you can tell from her nipples pointing towards the ground. But she was able to undergo a mastectomy. She had immediate implants placed. This is after the first stage. And then at the second stage, she had nipples done. She had not gotten her areola tattoos yet. But if you look at how she was before, how she is now, it's a pretty good result, given an immediate implant reconstruction, and she's happy with her result. For those patients who don't have good enough skin or enough tissue to have an implant placed right away, again, the patients I just talked about is a small number. So most people come out of a mastectomy not having enough skin. They'll often, if they're going to undergo implant reconstruction, they'll have what's called an expander placed first. It is a plastic material that actually has no saline in it or silicone. It's deflated, and it's placed in the same location as the implant. The skin is closed, the patient heals, and then in the office over the next few weeks, saline is basically put into the expander to expand it and to stretch the skin and muscle, basically creating a pocket so the implant can then be placed. 4 weeks after the final expansion, the patient would go back to the operating room, an implant would be placed, and the patient would then 3 months later undergo their second stage. The tissue expander is also a good modality if the patient's going to undergo radiation. If the patient's going to undergo radiation at the time of mastectomy, an expander can be placed. The wound will be closed. The patient can have radiation to the expander, whether it's filled with some saline or not. And then after radiation, after the patient's healed, at least 6 months after radiation, the patient can then undergo either implant placement or autologous reconstruction. So it does have a role there. The advantages of implant in general reconstruction are that it's safe, it's simple, there's no scars anywhere else because you're not taking tissue from another part of the body. There's typically a quick recovery, and you can get good results in the right patient. Disadvantages are that there is a lifetime risk of complications. Now that sounds kind of scary. I've thought about how to reword that, but as long as you have an implant in your body, there's always a risk, small risk, that you could develop an infection that would make you have to remove the implant. The implant doesn't cause an infection, but there's a risk that you could get one and have to remove the implant. There's a risk that the implant could rupture. Generally, after 10 years of having an implant in, you start to talk about maybe replacing it. And then again, I've mentioned capsular contracture is always a risk where your body might form a scar around the implant causing pain. It's a little bit harder to form a good symmetry versus the opposite breast. If you have normal aging of your opposite breast and then you put an implant which sits high, it's hard to make it look the same. And in the end, there's more procedures in the long term versus an autologous reconstruction. But implant reconstruction does have its place in reconstruction. Some women come in and they don't want to go through what it takes for autologous reconstruction. They want something quick. They want to get on with their lives, and so you can get a good aesthetic outcome, and women are happy. Autologous reconstruction, on the other hand, again, uses your own skin, fat, or muscle, some combination, to form a new breast. Again, it's like with like. You're placing tissue with tissue. It's warm, it's alive, it's your own body, it's easier to match, and it's preferred in radiated patients because some of that skin that gets not only a change in color after radiation, but it does get firm and scarred. We can remove a lot of that tissue and put new tissue there. So in my practice, I prefer it in my radiated patients. The cons are that you have a new donor site on the front end of your reconstruction process. It's a little more detailed. You have to your surgery is a little more involved because you do have another donor site. You're taking something from another part of the body. And in free flaps, which we'll talk about, there's always a risk of having a flap loss. It's a very low risk. In very experienced hands, it might be 1%. But if you lose your flap, you've gone through this procedure and you're kind of starting from square one. We have lots of options and we move forward, and doesn't mean you don't have a successful reconstruction, but it's a risk that patients need to know about. The most simple form of autologous reconstruction is a pedicled flap. It's where we basically take that tissue and move it over without disconnecting the blood supply. A good example of that is called a latissimus flap. It's where you take the muscle from the back with some skin, the blood supply, which is attached to it, never gets disconnected, and you move it around to the front of the chest and recreate not only the breast, but also replace any skin that needs to be replaced. It's often comboed with an implant as well to add volume, because not much volume comes from the latissimus. It's mostly used to add soft tissue for the healthiness of the pocket and to cover the implant. Here's an example of a young female who underwent mastectomy, immediate reconstruction with a latissimus and an implant. So she hasn't undergone her second stage, but she has nice symmetric result. But the back scar is not insignificant. I mean, she has this is early on. It'll fade and soften, but she does have a scar, and we have taken one of her muscles. Now, literature shows that there isn't a big functional deficit, but we've gotten to the point with our reconstructive efforts where if we don't have to take muscle, we don't, because we would prefer to leave it there for function. So latissimus flap is a great option, but it's our second or third option if we need to on a patient. Excuse me. Another pedicled option is called the tram flap. Very common, in my mind, older school type option, though still performed in some areas of the country. And this picture, I looked for a lot of pictures on tram flaps, and I couldn't find one that actually showed a true representation. It makes it look like you take some of the muscle, your abdominal muscle, leaving some, but you take the full side of the muscle. You take all of this muscle and skin, and you move it up on a pedicle to the breast. And you can get a good result from it. But it does remove the muscle. It causes a risk for a hernia, and there's risks of complications that we'd rather avoid because we can't avoid them. That brings us to free flap breast reconstruction. This is kind of our specialty. You actually you take tissue from one part of the body, disconnect the blood supply, move it to another part of the body, in this case the breast, and reconnect the vessels to supply blood under the microscope. It's living tissue. It does require a specialized skill set. We're able now to, you can do a free flap with a tram like I showed you, but we don't do that. We do it with just skin and fat, and so you're able to minimize donor site morbidity. And because we move it from any part of the body, that gives you lots of options, and I'm going to show you some of those. The gold standard is called the deep flap. It's the deep inferior epigastric artery perforator flap. It's just named after the blood vessel that runs under the muscle. And this is the muscle in a cross-section that I showed you on the tram flap. We found that there's actually little blood vessels that go through there, and we dissect these blood vessels out, leaving the muscle. And so we're able to take skin and fat from the belly, leave the muscle down, and then move it up to the chest wall, connect it to the blood vessels in the chest, and form a new breast mound. Now, here's an example of a young woman with left-sided breast cancer. She underwent mastectomy, immediate reconstruction at her first stage, and I'll notice two things. You know, we have the skin, we call these skin paddles. This is skin actually from the abdomen, and this is what you look like after your first stage, but also she does have some, we call these dog ears from her surgery from removing the tissue. And so when she gets her second stage, we built nipples for her. We removed those dog ears. And then at her third stage, she can have the tattooing done right around that area, and she'll have a very natural-looking breast. Another area where we get tissue from is the upper buttock area. We call it an S-gap. A lot of these are based on the artery, but it's a gluteal flap. Again, the stomach is our first choice, but if for some reason due to previous surgeries or being too thin, we have to sometimes go to our second option. And this is one of our second options, the gluteal flap. And here's a female that had bilateral reconstruction. This is after her third stage, and you can see the scarring. This is a nice result. Sometimes the scarring in the upper gluteal crease will be a little scalped, a little hollowed out, and we'll do some fat grafting to help replace that. The profundo artery perforator or the medial thigh flap is our number 2 choice right now when patients get free flat breast reconstruction. We are able to take tissue from, this one is designed more posteriorly, but it's really posterior medial, and the scar then lies right up under the crease in the buttock and gives a nice aesthetic result. This is pre and post reconstruction. A new flap that we are just now working with, there's been papers on it, but we're just trying to see how we like it, how women like the donor site, is the lateral thigh flap. This woman had radiation, had an implant failure, and so at this point she needed to have autologous reconstruction. Implant reconstruction would not work, so we reconstructed her with lateral thigh flaps. And the incision here is not too much off from the gluteal one, but it does wrap around a little bit. And then as we get more efficient and we do these operations faster, we're able to do multiple flaps. And so in a woman that needs more volume for her breasts than the abdomen can really offer, we'll do what's called a stacked flap, or we'll double up flaps on one side. So this woman, these are our pre-op drawings. This woman's going to have one of her abdominal flaps and one of her PAP, we call it PAP flaps, combined to recreate each breast. And this is a woman who had just that. You can see pre-operatively, she's lost over time some volume in her breast, and we were able to replace that with her, stacking the flaps. And so we've gone kind of from just replacing a breast mound to now we're trying to, our goal is to really refine this reconstruction and really focus on the aesthetics of it, to really bring back an identity in that sense to a woman. And I think that one thing I didn't include in the talk, but I think it's very important to say, is that I've shown you a lot of reconstructions. You may go see a plastic surgeon, he may only offer you implant reconstruction because that may be what he does and that's what he does best. And so that's probably what's best in his hands. Or you may see somebody that just offers you autologous reconstruction. That's probably what that doctor does best in his hands, and that's important. And I urge you, if you're ever needing to undergo reconstruction, to think about getting second opinions, because it's never looked down upon to hear other sides of an option, because breast reconstruction, any type of reconstruction, it's not an algorithm. Some of it is, but the majority of it is, there's multiple options. And so it's that option that's best for that patient with that specific surgeon. So again, there's many reconstructive options, but we strive for perfection reconstruction with education, communication, teamwork, and a coordinated, successful plan. Thank you.